Gear Theory 2, Unit 2, Part 5, Complications in Pregnancy. And I think we might have touched on some of this last week. There are times I have to be honest where I feel like I've covered a topic, but I haven't because I'm covering same sort of topics, the PCP level, just slightly different right now. So whoever just changed the slide, if you could not touch the slides, that'd be great. One of the unfortunate parts about giving over control is it gives you the ability to move things around. So please don't adjust the slides because it puts them out of order. And when you change the slide, everyone else sees the change in slide, so we get ahead or behind ourselves. Anyway, so this is a list of topics we're going to talk about this morning. And we'll start with Braxton-Hicks contraction and draw the distinction between Braxton-Hicks versus true labor. So I have a feeling we talked about this because I think, Tanya, you talked a little bit about Braxton-Hicks last week. Did you? I can't remember for sure.
Yes, I did.
That's what I thought. Okay. But we didn't cover these slides, correct?
We're talking about it in an earlier lecture.
Yeah, okay. Yeah, separate topic. Okay. So Braxton-Hicks, often referred to as false labor, can happen as early as 13 weeks, and it happens when the uterus begins some intermittent contractions. Now, I can hear some noise in the background, and if you know who that is, if you just mute your mic, that would be helpful. Some of you are shutting down your mic rather than muting it, I think, and that might create a problem for talking later. But anyway, so theoretically, it may help to enhance blood flow. That may be a reason why there are false labor or early contractions. And they're typically painless, irregular contractions as opposed to labor contractions, which are more painful and tend to be regular. And they don't cause any cervical changes. So not that this is a pre-hospital assessment anyway. We're certainly not going to be doing that. And so here's some of the following traits for Braxton-Hicks in contrast with regular labor. So one, it's irregular, whereas labor tends to be regular. It decreases with walking, just the opposite with labor. May ease with change of position, no increase in frequency or intensity, and the discomfort tends to be located in the abdomen only, as opposed to true labor, in which contractions are more likely to be regular. Walking increases the intensity of contractions. That's often why you see women in labor who are walking around the birthing unit. Not affected by change in position, frequency and intensity increases, and the discomfort oftentimes starts in the back and spreads to the abdomen and maybe the upper thighs. So in terms of management, it may be difficult to distinguish true from false labor or early miscarriage. And so we're not going to do a whole lot in the field in terms of assessment. I'm certainly not going to, as a paramedic functioning in that capacity, I'm not likely to tell a mom, don't worry, this is just false labor. I'm going to treat it as premature labor and take them to the hospital and let them rule in Braxton-Hicks, rule out true labor. So not typically a field assessment. And so in terms of care and transport, at that, hang on a second here, my slides are not advancing properly. Let's just okay, I see what's going on here. So in terms of care transport, just you feel free to either write in the text or write on the whiteboard. And Charles, since I don't think you were here before, and I don't know if we lost Charles. Oh, there he is. Charles is there. The text boxes are to the left, and don't choose text 2, the big A. Choose the box right above where it says text to write on the board. This board, not the whiteboard. No, this board. And please stop changing the slides on me. I'll just get rid of this altogether. There we go. Now we can't mess with it. I see your text message, Brad. We couldn't hear you on the mic, but okay, can you guys start writing on the text? Just tell me what you would do if you're transporting someone with Braxton Hicks in terms of basic care. Or would you do anything? Okay, vitals and ongoing assessment, good. Okay, fair enough. Anything else? Thanks, James. Anyone else want to add to that? Okay. All right. Well, I think we'll leave it at that. We're not going to be administering O2. What about left lateral position? Is that necessary? Excuse me. Okay, I'm just giving you the writing function here. I think everyone should have the writing function now. Well, again, keep in mind that Braxton Hicks is going to be less than 20 weeks in most cases. So anything over 20 weeks, we think of premature labor rather than Braxton Hicks. Okay, I'm going to move the slide since we're not getting any text on the board here. So supine hypotension is this situation where a gravid uterus, usually third trimester, is pressing on the inferior vena cava. And so consequently, these moms may become hypotensive, and probably a good idea to put them left lateral recumbent. Although I was reading a paper last year which suggested that left lateral recumbent position really doesn't make much of a difference. But right now it's still the standard. So we elevate the right hip with maybe a blanket or something, a rolled blanket or a pillow, and monitor maternal vital signs. Last week we talked about fetal heart tones. Personally, I avoid even attempting to auscultate fetal heart tones because if I'm not able to hear them, I'm worried that that's going to raise some concerns for mom. ECG would be reasonable to monitor, and SpO2, O2. I think if we're looking at a woman who is in labor or in distress and has called 911, oxygen would not be unreasonable, probably by nasal bronchs. Not likely any need to use a non-rebreather mask, but it depends on the circumstances. If there's significant bleeding, then an NRB might be more appropriate. IV TKO, probably a good idea, and fluid resuscitation generally not needed unless there's significant bleeding. Or the left lateral recumbent position doesn't correct any symptomatic hypotension. So let's talk about different complications in pregnancy, including ectopic pregnancy. This is just out of curiosity, and I'm going to create a poll here. Stand by. Okay, publishing the poll, and if you want to click on the results or choose your answer, one or two. So we've got 3 votes in so far. Unfortunately, I'm not able to participate in the voting system. So we got 8 votes in so far, and I don't think we have more than 8 students in the room. So looks like most of you have transported an ectopic pregnancy, and some of you have not yet. So let me just end this poll. Let's just take a look at this form, see what it says. Okay, cool, fair enough. Okay, let me just end the poll. And get rid of that. Just out of curiosity, what was, hang on a second here. Anyone want to share their experience with their ectopic pregnancy patient? Feel free to use your mic. I don't know if you guys are quiet this morning or it's just an internet connection thing. Okay. All right. Well, we're going to move on. So places where an ectopic pregnancy may occur include the fallopian tubes, the cervix, the ovary, the corneal region of the uterus, and the abdominal cavity. And I've got an image coming up here. So this ends in death of the fetus, obviously, and can be a life-threatening situation for mom. It's a leading cause of pregnancy-related deaths during the first trimester, and usually happens within about the first 6 weeks. And moms usually present with severe, sharp lower abdominal pain. So these are some examples of places where a fertilized egg may begin to develop. And so the etiology is anything that hampers the migration of the embryo to the urinary cavity. And those include things like pelvic inflammatory disease. If they've had previous ectopic pregnancies, that's a problem. Or history of tubal surgery and conception after tubal ligation. Women who are using fertility drugs are at high risk. And age and smoking is also a risk factor as well. However, having said that, most patients have no clear identifiable risk factor for ectopic pregnancy. So presentation, I think we talked about, there's a classic triad of presentation, including pain, amenorrhea, which is absence of menstrual periods, which is usually a sign they're pregnant, and vaginal bleeding. Although I've had 2 really serious ectopic pregnancies where there was no vaginal bleeding at all, and only about 50% present classically. And so some patients may present also with early or symptoms commonly associated with early pregnancy, things like nausea and breast fullness, fatigue, lower abdominal pain, heavy cramping, shoulder pain, vaginal pain, or pelvic pain experienced during sexual intercourse, all typically signs of pregnancy. And so important to assume that any woman of childbearing years with lower abdominal pain is experiencing an ectopic pregnancy until proven otherwise. And remember that it's a potentially life-threatening condition. So we monitor SpO2, although it's important to remember that if there's bleeding, that the SpO2 may be falsely high, maybe 100% when their oxygen carrying capacity is reduced. O2 by nasal prongs is reasonable. ECG, left lateral recumbent, although these pregnancies are usually early on in the first trimester, so vena cava hypotension is not usually an issue. IV access and fluid resuscitation (PRN) and transport to the hospital. So abortions, both therapeutic and elective, just out of interest, worldwide there are about 20 to 30 million legal abortions, and another 10 to 20 that are performed illegally, generally in developing countries. Um, Hopefully not in Canada. Uh, yeah. So sorry, I'm just noticing your question now, Charles. So my preference is on the slides rather than the text area because I my eyes are usually on the slides, not on the text box area. So abortions performed, just for your interest, performed 1 to 2 weeks after conception are termed menstrual extractions. Um, Performed 9 weeks after the last menstrual period, or 7 weeks from conception, are performed surgically or medically, and 9 to 14 weeks are performed by dilatation, suction, and curettage. After 14 weeks, surgical abortion is performed by dilation and evacuation procedure. I wonder how often that happens. That sounds pretty horrifying at that stage in the pregnancy. So some post-abortion complications, typically pain, bleeding, and low-grade fevers, most commonly, and usually the result of retained products of conception rather. I think I was covering burns in the PCB class, the last class. That's probably why I've got burns on my brain, or combustion on my brain. There may be excessive hemorrhage or shock. The last time I had someone who had post-abortion complications was a coworker at who was bleeding in the bathroom, and the entire floor of the bathroom was covered in blood. And we started a couple of lines on her. We gave her almost 4 liters of crystalloids before we got to the hospital, and apparently she ended up needing 12 units of blood in the hospital. She nearly exsanguinated on us, and she was in her early 20s, and she was pale as I've ever seen anyone who's pale from hypovolemia. One of the other problems too, in the long run, is coagulopathies occur with post-abortion complications. So they may have increased lower midline abdominal pain, and uterine perforation is also a potential problem. There may be bowel injury with abdominal pain, fever, blood in the stool, nausea, vomiting, bladder injury with suprapubic pain and hematuria. So it's important to ask about stooling and micturia, and ask about blood in the urine or the stool. And with a septic abortion, they may be septic. So fever, chills, abdominal pain, either fever or hypothermia, pain and vaginal bleeding. And then failed abortion would be continued intrauterine or ectopic pregnancy. So in terms of management, spontaneous or therapeutic abortions have similar risks of hemorrhage, so we treat for shock, PRN, SpO2, O2, ECG, left lateral recumbent. Although again, this is likely not an issue because of the gestational age. And in terms of management of shock, initially, a 20 cc to 30 cc kilo per bolus, and then we move to inotropes. And there's been talk, and it's too bad MJ's not here, but there's been talk about adding Levofed, which is an alpha agonist, to our drug list. Now, I just did my base hospital CME, and we got ketamine and we got fentanyl back, but no word on things like Levofed or oxytocin. Even oxytocin is still a possibility for next year's CME. So we'll see. So, in terms of shock management, well, I've already said fluid resuscitation initially, and usually no more than 20 to 30 cc's per kilo, followed by inotropes. So when you get to the 20 cc per kilo mark, you'll want to, or when you're close to it, and you're not making any headway in terms of pressure, you'll want to patch the base hospital and see if they want you to give another 10 or 20 cc's per kilo, or if they want you to start the patients right on dopamine. Again, this is for septic shock, right? Not hypovolemic shock. We don't treat hypovolemic shock with inotropes ever. So preeclampsia is hypertension in pregnancy. It's the most common hypertensive disorder, accounting for about 50 to 70%, and sometimes referred to as toxemia of pregnancy. And terms used include the patient's toxemic or the patient's preeclamptic. And the etiology is not really known, but one of the hypotheses is that some sort of placental dysfunction can initiate systemic vasospasm, ischemia, and thrombosis, and ultimately that may lead to organ damage. So occurs after 20 weeks gestation, unless there's a pre-existing chronic hypertension, but that wouldn't be preeclampsia, that would be just chronic hypertension. And it's one of the most common causes of perinatal morbidity and mortality. My niece, interestingly enough, had postpartum preeclampsia. I'd never even heard of that. She was, I guess, hypertensive after giving birth and remained so for about a week. They kept her in hospital for 5 days. So mild preeclampsia would be a relative increase in systolic and diastolic pressure of about 30 systolic and 15 diastolic, and or an absolute reading of 140 on 90, which is the standard number for diagnosis of hypertension in non-pregnant patients. There may be mild peripheral edema, headaches, protein in the urine, and severe preeclampsia would be systolic greater than 160 or diastolic greater than 110 or both, with ultimately that can lead to end organ damage. Headaches, visual disturbances, confusion, right abdominal pain, typically right upper quadrant pain, and oliguria, peripheral edema, pulmonary edema. Again, this is why it's important to auscultate the chest in mums. And in terms of management, I'm a little puzzled to this day as to why we don't have magnesium sulfate, which is such an inexpensive electrolyte and would be useful for things like premature labor, preeclampsia, severe respiratory distress, a whole host of different things. But we'll see. All right, the slides do not seem to be advancing. So eclampsia is defined as a seizure or coma during pregnancy, and preeclampsia can lead to eclampsia, likely due to encephalopathy from the high blood pressure and an increase in intracranial pressure. Only occurs in about 0.2% of pregnancies. I guess that's good, but unfortunately we see our rate of complications in pregnancies in the out-of-hospital setting is about 6% compared to 1% in hospital, because we see few pregnant patients, but the ones who call 911 are a little more likely to have complications than the ones that don't call 911. So this is life-threatening, and generally the cure is delivery of the baby. So intracranial hemorrhage is a major cause of maternal death, and maternal death equals fetal death, obviously. So in terms of management for eclampsia, I think my text box is here out of order. I think I was looking for answers from you guys, but how would you manage a seizuring pregnant patient? And feel free to write on the Versed. Good. I was hoping you guys would write on the whiteboard, but that works for me. Yep. So IV access and Versed. Good. And check blood sugar, obviously. That's number one. With any seizuring patient, we check blood sugar first, and then midazolam. So on that subject, blood sugar, gestational diabetes. What was I going to say here? So in terms of we want to consider hypoglycemia in a patient who has a decreased LOC. If they've got if they're IDDM to begin with, then they could be a diabetic ketoacidosis, or they could be hypoglycemia if they've got an altered LOA. So we want to check blood sugar and administer D50 as indicated. Glucagon if D50 is not an option because we can't get an IV access. In terms of neuromuscular diseases, hopefully we'll never run into those. I've never run into anyone with a myasthenia gravis or a Guillain-Barré or anything like that. Just out of curiosity, have any of you ever run into a pregnant patient with a neuromuscular disorder? I feel like we've had this discussion, like we've done the set of slides before. But Tanya, you're saying we didn't?
I'm not 100% sure
You're not?
because I know we've had this discussion before too, but I don't remember going through these slides.
Yeah, me too. Maybe it was just a little bit of a part of the other slides. But anyway, so myasthenia gravis, just as a quick review, is an autoimmune disorder in which the acetylcholine receptors are destroyed, and they may experience abdominal wall weakness, chest muscle weakness, and so it may be very, very difficult to deliver under those circumstances, and possibly respiratory failure. So it's a rare occurrence, fortunately, and hopefully none of us will ever encounter that situation. So if you ever encounter a pregnant patient with a neuromuscular disorder, or any patient for that matter with a neuromuscular disorder, and you're not familiar with it, ask the patient, because I'm fairly confident that they'll know their disease quite well and what their concerns are, particularly when it comes to pregnancy and labor and delivery, and what the plan, you'd want to find out from her what the plan is for labor and delivery. So that patient may be going to a special hospital, but may require transport to the closest hospital under the circumstances. Again, how you deal with that will be on a case-by-case basis. So respiratory assessment in neuromuscular disorders will be fairly critical. Are they short of breath? Are they dyspneic? They're likely to tire quickly. We want to sort of roughly gauge the respiratory rate and tidal volume and get their SpO2 and LOA. And they may not have the strength to push to deliver the baby. That's the big concern. So management would be SpO2, ECG, O2, PVV, PRN, left lateral recumbent, IV TKO, and transport. Placenta previa. So this is a normal implantation of the placenta over the lower half of the uterus, and they may experience painless bleeding in the third trimester. And obviously we're not going to do a vaginal exam. We wouldn't anyway. We're going to treat for shock. Oops. And rapid transport. So here's some examples of placenta previa, the one on the left being total and the one on the right being a partial placenta previa. And so delivery can cause some serious life-threatening bleeding, and so that's a concern. We want to avoid delivery in the field if at all possible. So treat for shock, SpO2, ECG, O2, left lateral recumbent position, IV. We may even need to put them in a hand-knees position to prevent them from delivering, or Trendelenburg might be another option. It might be safer to secure them with a stretcher in a Trendelenburg position. Fluid resuscitation, PRN, and transport. So these pregnancies have to be delivered by C-section. Abruptio. Now, just out of curiosity, have any of you had placenta previa or abruptio placenta patients? And do you want to share your story? All right. James, did you want to tell us about your case? those who said no or negative, I really appreciate it because at least I know somebody's listening. The trouble with teaching live is I'm talking and I never know for sure if anyone's actually there. Okay, Charles. Before you log out, Charles, it may be something at my end that I can do. Let's see. I'm not sure here. No, you just have to unmute your mic. All right. Well, if anyone wants to jump in, feel free to do so at some point. So this would be a life threat to mom and fetus, obviously, and maternal death usually and fetal death occurs because of hemorrhage and coagulopathy. Yeah, no need to tell us where the call was, but 150 Stolic, okay. So James was describing a abruptio placenta case in which the patient was hypertensive and was transported to, I'm assuming, is that the closest hospital, just out of curiosity? Okay, interesting. So abruptio placenta can be classified as partial, severe, or complete, and mom will probably know just exactly what kind of abruptio placenta that she has, or what kind of, well, I shouldn't say that, placenta previa she would know. So abruptio placenta is a different story altogether, and here are some examples. So there may be abruptio placenta with occult bleeding or concealed hemorrhage, as we see here in this image, a partial with obvious hemorrhage, and then there may be complete with severe hemorrhage as well, and there'd be severe abdominal pain with that as well. So signs and symptoms will vary, but vaginal bleeding occurs in about 80% of abruptio placentas. Abdominal or back pain and uterine tenderness about 70% of the time. Fetal distress 60% of the time, although that's not something we assess, so that's why I put an asterisk there. And there may be abnormal uterine contractions, so they may be hypertonic or high frequency. That happens about 35% of the time, and idiopathic premature labor about 25%. So when you're encountering early labor, you have to consider something like abruptio placenta. So causes include maternal hypertension, maternal trauma, cigarette smoking, alcohol consumption, cocaine use, short umbilical cord, premature rupture of membranes, delivery of first twin, and retroplacental fibromyoma, advanced maternal age, and then another whole other category of we don't know why. So management, treat for shock, left lateral recumbent, SpO2, O2, ECG, IV, fluid resuscitation, PRN. Premature labor. So that's the presence of contractions with sufficient frequency and intensity to progress to affect effacement and dilatation, or dilation rather of the cervix prior to full term. Usually occurs in 20 to 37 week range, and happens about 12% of pregnancy. It's a leading cause of neonatal mortality. And preterm premature rupture of the membranes, or PPROM, is associated with 30 to 40% preterm deliveries, and is a leading cause of preterm delivery. Risk factors include smoking, previous preterm pregnancies, vaginal bleeding at any time during the pregnancy, and premature rupture of membranes, or PROM, occurs at 38 weeks or later. So precipitating factors include infection, vaginosis, STDs or STIs, UTIs, etc., uterine distension, multiple gestations, excessive amniotic fluid, uterine distortion, incompetent cervix, abruptio placenta, placenta previa, and hypertension and IDDM as well. So other precipitating factors include cardiovascular disease, renal disease, past history of preterm labor, any patient who's had who's multiparous, trauma in pregnancy, oops, drug abuse, smoking, alcohol consumption, stressful life, so things like domestic violence or a recent family death or poverty or insecurity about a love partner. And there's some hypothesis that the fetus may initiate labor, and so the fetus recognizes a hostile intrauterine environment and precipitates labor. So there's been some talk about interventions that some sort of way of reducing fetal distress, and I'm not sure what that would be, whether it be sedation or some other strategy. Now, just out of curiosity, I didn't know this until my wife was pregnant, but did you know that nitroglycerin is a tocolytic, that it reduces labor or relaxes the uterus? You can write in the text box if you want. My wife had a C-section, and the uterus was contracting, and I was there sitting with the anesthetist. Actually, the anesthetist was a friend of mine, a doc I taught ACLS with, and we were chatting, and the other doc who was delivering said that asked him if he would give nitro, and he asked me if I would give her the nitro. He said, "Rob, you're the paramedic. You give her nitro." So so I did, but she's lying on her back, and I'm prepping the nitro, and I, tell her what to do, lift her tongue and everything, and then I go to spray, and she starts talking. So I hit her chin with it. And I said, "Honey, you got stop. You got to stop talking and lift your tongue so I can get it under your tongue." Anyway, ever since then, she's harassed me about giving nitro to patients. When I go off to a shift, she says, if you got to give nitro today, make sure you get it under the tongue, not on their chin. So Chris, you're asking, but if you have someone who's at risk of bleeding, would you not want the pressure drop? Well, first of all, we're not going to give nitro to any pregnant patients. We're not ever going to use it as a tocolytic. This is just a surgical thing where, she was normotensive and she was getting a C-section, and the doc wanted one spray of nitro, so it's definitely not something we would do anyway. And yeah, for sure, if they're hypotensive, I would think that's probably not a good idea. So in terms of management, sorry, these slides are a little out of sequence. So SpO2, O2, ECG, left lateral, IV access, and rapid transport to avoid delivering the field if that's at all possible. But we want to be prepared for precipitous delivery because the baby's preterm, they're going to be small, they're going to deliver pretty easily, I would think. So that's it. Any questions about complications in pregnancy, delivery?